All right, so it is my pleasure to introduce our next speaker, Dr. Kate Sigford, who is pediatric PNMR faculty here at UCSF and an associate clinical professor in the Department of Orthopaedic Surgery. They also are the medical director of our Peds rehab program at BCH Oakland and also the medical director of our cerebral palsy program. They did their PNMR training at Stanford University and fellowship in pediatric rehab medicine at Gillette Children's Hospital at University of Minnesota. They joined us here at UCSF in 2020 from South Dakota, where they were the chief, actually, of the Peds rehab department there.
Of 2 people.
Still counts. They've been an active member of the American Academy of Cerebral Palsy and Developmental Medicine and has served as the former chair of the membership committee. So today, Dr. Sigford will be talking to us about pediatric indications for Botox injections. Welcome.
Thank you. Thank you. All right. There is one of the most common questions I feel like I get, well, after I suppose, will my child walk, is, can you fix this with Botox? And so I'm going to try to do give some insight here as to what we can fix with botulinum toxin and what we can't, and what might be helped, and what some of the pitfalls are. I have no financial disclosures. I will discuss off-label use of medications, though every time I give this talk, fewer of the indications are off-label because they do keep getting additional approvals, which actually is good. Botulinum neurotoxin is produced by the Clostridium botulinum bacteria and has 8 serotypes. Types A and B are used medically, and where they work is at the axon terminal where it connects to the muscle. Let me get the laser pointer going here. There we go. You may remember from your physiology class, or you may not because it was a long time ago, that the axon terminal does not actually directly connect to the muscle. You can see this gap here. Instead, the nerve releases a little bit of releases acetylcholine that binds to the muscle and tells it when it's time to fire. All of the botulinum toxins prevent release of the acetylcholine. They all interrupt the mechanism in slightly different ways, but they all work in essentially that same way. When Botox starts to work is not necessarily, people won't notice it exactly as you inject it, but often it starts to creep up and people notice within the first 3 days. Peak effect is by week 3, and the duration is about 3 months. So I do caution folks when I do the injections not to expect something immediately and not to be disappointed in the first week if you're not seeing everything that you ever wanted and then some. Administration interval used to be 3 months pretty routinely, that it was repeated every 3 months because that was the approximate duration of action. It is also what the original formulation botulinum toxin A, or brand name Botox, was approved for in adults by the FDA, administration interval. Administrations that frequently are falling out of favor for a number of reasons at this point. The first is that a shorter duration of time between injections increases the risk of developing antibodies. The human body can learn to recognize at least some of the commercially available botulinum toxins and ultimately mount an immune response to the injection that leads to them becoming less effective over time. So we want to avoid that. Usually switching to a different toxin will alleviate that, at least until the next one's built up. There's also concern over effect of repeat injections on muscle volume and composition. And this has been something this has been actually a line of thought that's been through a number of changes through the course of my career. First of all, we know that there are baseline differences in spastic muscles. The muscles in kids with CP have reduced length overall and fascicle length and volume compared to their typically developing peers. And initial muscle changes are discernible prior to 12 months of age. That means they really pretty much start out this way. It's not something that evolves later on in life as a result of treatments that we do. And on the microscopic level, there's a shift towards type 2X or fast twitch glycolytic fibers. The original concerns about changes of muscles with use of botulinum toxin came out of animal studies and healthy adult studies that showed really quite major atrophy in muscles treated with botulinum toxin. The animal studies were pretty high dose. The adult studies were on typically functioning adults with healthy, normal muscles. And so we're not really good models for a lot of the kids that we're using botulinum toxin on. More recently, a few groups, including one group out of Belgium at KU in Leuven, has been taking more careful looks at the effects of botulinum toxin on muscles in children with cerebral palsy. And what they're finding is the atrophy effect there is not as great as it was in the adult studies. They do find that there is atrophy of the medial gastroc at 3 and 6 months post-injection, which is the major muscle that they've looked at. But between the 3-month and the 6-month point, the muscle is starting to increase in size. They're still following it out to see when it gets back, to see when or if it gets back to where it started. They've also followed the microscopic characteristics to find that there were alterations in fiber size and proportion of different fiber types in the short term, with normalization in the medium to long term. And long term, in this case, the study went out to 12 months. So by 12 months, the muscle composition was real similar to where it started. All of this put together suggests that you probably want a dosing interval of at least 6 months between administrations of toxin if you want the muscles to have a chance to recover. Now, the toxins commercially available in the United States are this list, and we're going to come back to them in just a second. One of the problem with the different toxins is that they're all measured in units. One unit is the amount of toxin that kills 50% of a group of mice. And but how many units you want to use for any indication in a person is different, and they're not interchangeable. So you can't say, well, I gave this person 50 units of Botox, so therefore I should give them 50 units of Myoblock, so therefore I should give them 50 units of Dysport. They're all completely different. The one exception being Botox and oh God, I'm going to lose it. The one that I always forget the name of are pretty similar. It'll come back to me in a minute. Adverse effects, generally mild for the vast majority of the kids that are injected. It's an injection. It can hurt. It hurts when you do it. They get mad. Maybe there's a few drops of blood, maybe a little bit of bruising, but for the majority of kids, that's it. However, we do have to talk about the more serious things, including the fact that the botulinum toxins carry a black box warning that all of them may spread to distant muscles, and life-threatening swallowing and breathing problems have been reported. And not just life-threatening, but actually fatal. This is most common, and these is more common in kids highly affected with CP than in the general population of folks injected with botulinum toxins. Seems to be a bigger problem in folks who already have pre-existing problems with their breathing, with their swallowing. Still very, very, very rare, but is something that does happen. Other injection problems, the other one that's more common but less major, is a little bit of muscle soreness after the injection that might feel like when you get your flu shot and that muscle gets sore. I've had a couple patients who've told me, no, it's not a flu shot, it's a tetanus shot. A tetanus shot hurts more, and that's more like what a Botox shot gets sore like. But either way, that's a level of pain that lasts for a couple days. It's doable. There seems to be a higher incidence of upper respiratory infections immediately after injections of toxin, and that's still not quite understood. Why exactly that happens is still not quite understood. Muscle weakness, well, is that an adverse effect, or is that the goal of the injection? Maybe a little bit of both. The pediatric uses of botulinum toxin are for spasticity in the upper and lower extremities, for congenital muscular torticollis and cervical dystonia, for birth brachial plexus palsy, sialorrhea, and up-and-coming migraine. The commercially available botulinum toxins are here. Of them, only abobotulinum toxin A or Dysport and onabotulinum toxin A or Botox. Actually, we do the majority of our work with those two because they have the largest pediatric approval. Incobotulinum toxin A does have some pediatric indication too, but I have not done a whole lot of use with it. That's the one that I lost a minute ago that has relatively similar dosing to Botox. Then there are a couple that have approval only in adults, and the last and one of the newest ones, which is only cosmetic. So first indication, spasticity, and for I think some of the folks that I know in this room, at least the therapists out of Children's and the MTUs, spasticity is one of the biggest things that you're thinking about. First, what is spasticity? It's velocity-dependent. It's a velocity-dependent resistance to stretch of a muscle. So the faster you try to stretch out the muscle, the harder it is to stretch. If you go nice and slow, it stretches out okay. If you speed up, you get a catch, and you have to slow down to finish. And so that's spasticity specifically. That's one of the major kinds of muscle tone that the toxins will help with. And you've got to distinguish that from contracture, which is where the muscle length is that long and no longer. You can stretch and stretch and stretch and you never get anywhere. One of the big reasons that I've had people come back and tell me it didn't work, or yeah, that other doctor did Botox and it didn't work because their knee didn't get any straighter. Well, I do the exam really carefully and they have a fixed contracture. I can't fix a fixed contracture with botulinum toxin. Where did Jason go? That's Dr. Jagosinski's department, the orthopedic surgeon. So when would you want to consider tone management? If that hypertonia is interfering with function, positioning, cares, or comfort. You don't always have to treat tone just because it's there. You need a goal. And then you need to understand your goal well enough that you can figure out if you met it or not, so that you can measure the effectiveness of your treatment. Sometimes I get excited and get out of order. Here we are. This is a little bit more on what can and can't we expect botulinum toxins to do. Decrease spasticity or dystonia, which is a movement disorder. So folks try to make one movement but maybe end up with a twisting position or posturing that wasn't their original goal. It can make stretching easier, it can reduce pain, and it can improve function, but only as part of a larger treatment and therapy plan. Just giving someone an injection is not going to immediately improve their function. Another reason that I have people come back and say, well, it didn't work. They couldn't button their shoes, tie their shoes, or button their shirt. No, because you're going to have to practice. You're going to have to work on it. You're going to have to go see your OT. What can't it be expected to do? It can't be expected to lengthen contracted muscles, improve function in isolation, or last forever. Another common complaint. Well, you gave it and then it wore off. Well, yes. So in terms of muscles that we might think about treating or positions, here are some of the common upper extremity postures that we might see in folks with spasticity and treat, and some of the common upper extremity muscles that we therefore might need to inject. In the lower extremity, the officially approved muscles are just from the calf down and are the plantar flexors. We inject just about anything we can find in the leg if it's the muscle causing the problem, whether that's because there's too much inversion, too much eversion, also below the knee, whether it's because we're having scissoring gait or too much knee flexion contracture. Then next indication is for brachial plexus palsy. This of kind of all the indications is the one that surprised me the most as I started reading about it, because the problem with a birth brachial plexus palsy is that you have muscles that are denervated or only partially innervated and not working right. Why would I want something that makes muscles weaker? There are limited studies so far, but they suggest that if you inject the opposing muscle, then you can take advantage of having that freed up, of having the muscle strength and that muscle relaxed for a little bit of time to improve active and passive range of motion in the direction against that muscle. So it makes it easier to work into the direction of your affected muscle. The duration of the pretty limited studies at this point, and even the duration that improvement lasts once you get it, is not yet really well characterized. Then next is for congenital muscular torticollis, which is caused by shortening of the sternocleidomastoid muscle, and the trapezius and the scalenes may also be involved. This is congenital muscular torticollis because it starts out often noticeable from birth. Present from birth, usually noticeable, though occasionally folks don't really start picking up on it till later. They just think, oh, that baby's so cute. They always have their head a little bit turned. It leads to a head tilt to one side and looking toward the other. It's often accompanied by skull and or facial asymmetries. If you see a kid with plagiocephaly, look for torticollis. The incidence of co-occurrence is incredibly high, and you will have a hard time getting a good handle on your plagiocephaly without sorting out the torticollis. Physical therapy, despite the fact that this is in my Botox talk, physical therapy is the mainstay of treatment for congenital muscular torticollis. Success rates for physical therapy starting early have been quoted at up to a high of 100%. Pretty good. But PT has to start early, ideally before 4 months of age. And this is what I particularly want anybody who sees babies in any capacity to take home. I've seen too many kids come into my clinic at 8, 10, 12 months of age or even older, and their mom says, yeah, we started PT at 7 months because I told the pediatrician at our 1 month and 2 month and 4 month and 6 month well child visits that the head was tilted. And they said, oh, it's okay, they'll grow out of it. It's a small percentage, but any number is too much for something that is treatable when started early. There have been actually interestingly a couple of different studies. One that showed in a randomized controlled trial study that children who were stretched by PT 3 times a week improved faster than being stretched only by family members. There's also another one that showed that if you really get the family members dedicated and just give them a PT to call when they have questions, you can get just as good results. So we need a PT involved in the process somewhere. The studies appear to slightly disagree on how involved. If you can get the family to do the stretching routinely, diligently, every day. So when do we bring actually botulinum toxin in for congenital muscular dystonia? When conservative management has been tried unsuccessfully, when you've had PT, when you've had a home stretching program, when you've maybe used an orthosis. Generally, a 3-month trial of conservative therapy without adequate results is an indication to consider use of botulinum toxin. And then you need to continue the therapy. You need to continue the stretching afterwards. You need to continue the stretching if the child cries. You need to continue the stretching if you're bored, if you're busy. But botulinum toxin is now more and more often falling into the midpoint of treatment for CMT between PT and between surgical release. Also in the neck, you can use botulinum toxin for cervical dystonia, which is a movement disorder characterized by twisting motions or fixed postures of the neck. You actually can see dystonia anywhere, but you actually get specific FDA indications for cervical dystonia. Cervical dystonia is rare as an isolated finding in the pediatric population. Usually it comes in folks who have other movement disorders or involvement of other limbs. But botulinum toxins is an accepted first-line treatment. So the things that you have to figure out, actually, both for cervical dystonia and for any other time you're going to use it, is first, which muscles do you need to treat? In cervical dystonia, most commonly involved are splenius capitis, semispinalis, and sternocleidomastoid. Now, injecting in the neck, both here and for CMT, there's an awful lot of really important real estate in the neck. There are your muscles that control the neck movement, but there are also your swallowing muscles. There's also some really important blood vessels, and so you need to really pay attention to where you're going and use a localization technique. Often in the little tiny infants that we're injecting up at Children's, we take them to the OR to use anesthesia to be sure that they're going to be still, to be sure that we have all the time we need to use the ultrasound, to use the electric stimulator, to know exactly where we are. Then, lastly, for migraine, botulinum toxin has been an accepted treatment for quite a number of years for adults. It's not FDA approved in kids, but it works really well in adults, and so it's being tried in kids as well. There have been 2 randomized controlled trials, both since 2020. And one showed non-superiority to placebo, but it had some flaws. One of the treatment groups only got half the recommended dose, so I'm not sure why they thought that was a good idea. And they actually powered the study to detect a change in migraine frequency that was twice that of what was seen in adults. So I feel like they almost set the study up to fail from the get-go. The other showed efficacy, but was only 15 patients, and 2 of those were later diagnosed with idiopathic intracranial hypertension, so it wasn't a migraine to begin with. Nevertheless, we have really good data. We have really good data from a number of trials that it is effective in adults, And so certainly in your late teens, you can expect them, in your late teenage kids, you can expect them to be really pretty similar to grown-ups. Earlier than that, the earlier you get this, the more different folks are, but it's probably promising. We also then use it for sialorrhea or drooling. Why would we need to treat that? First, for perioral skin irritation. And actually, honestly, I don't see as much trouble with this here as I did in South Dakota, where in the winter that chronic moisture and the super cold, dry air led to really bad skin breakdown and chapping. California, here in the Bay Area, we're blessed with our climate and don't get into quite so much trouble. But aspiration and respiratory difficulties, articulation difficulties, and social stigma. The glands that are generally treated are the submandibular glands, which are most active in producing saliva at baseline, and the parotid glands, which are most active with stimulation. Again, we need good guidance for doing these because we don't want to get the muscles of mastication, to get the facial nerve, which runs right through here, or to have it spread to any of the muscles that swallow. Another possible side effect, if it's used for sialorrhea, is a dry mouth. Do we dry up the salivary glands too much, and folks end up feeling like they have a dry mouth? While we see the botulinum, and while we see the toxins wear off in the muscle effect over 3 months, and we do see it wear off for sialorrhea, but it seems that in this indication, over the course of enough repeated injections, eventually the salivary glands just sort of give up and stop producing as much saliva as they started at baseline. So you may get to a point where you don't need repeated injections, and you don't need to send the kids to see your ENT friend to do a duct ligation or anything else. And I know that we're doing questions for both of these talks at the end, so I'm going to hand the podium over.